All right, so diabetes labs and diagnostic tests. So basically, the only thing you're going to worry about is A1C. That is the best one, right? And that's end of story. So we know that when the sugar gets higher and higher and higher in the bloodstream, that's going to start. It's going to start getting super saturated. And if you remember back from chemistry, when you have something super saturated, it's going to start to crystallize, especially if it's prone to it. And glucose is definitely prone to it. It'll start crystallizing just like rock candy. That's exactly how rock candy is made in the factories. They put little sticks inside of super saturated glucose, and it starts forming crystals onto the stick, right? So in place of the stick, if you imagine a vessel, right, or you imagine a nerve ending, right, they're going to get crystallized with glucose, right, or crystallized with glucose on the vascular space, right? And if you crystallize it, it no longer becomes distensible, no longer becomes compliant or stretchy, right? So if it's not stretchy, that it doesn't stretch as well as it did before, that's going to cause a rise in blood pressure, right? Also, it's going to cause a vessel that is going to be hardened, and it's going to be cracky, and it's going to be looking like this, and this looks like perfect breeding ground for adipose or LDLs or cholesterol, right? So now you got cholesterol on top of the high blood pressure, and we know those two are just waiting for a stroke to happen or a heart to happen or peripheral arterial disease to happen, right? So that's the deal with what glucose does when it gets super saturated. The other thing that happens is you can imagine this is a white blood cell. So white blood cells become glycolylated. They can become glucose laden, right? So they're glycolylated hemoglobins. There's glycated white blood cells. There's glycated vasculature. There's glycated neurons, and it's also the vessels that feed the neurons as well. So it's like it's a catch-22. Your neurons get crystallized, and the vessels feeding the neurons get crystallized as well. And of course, the smaller the vessel, the higher the risk of that organ or nerve or whatever it may be is going to get compromised, right? That's why they develop peripheral neuropathy. They get like a stocking glove syndrome where they have their feet or their hands are very, very pins and needles like, right? So the A1C, here's a glycated hemoglobin. You can see all the hemoglobin is not going to be working that great. And really all we need is like 6.5%. That's it. 6.5% of my hemoglobin is glycated. That's someone that is diabetic. And end of story. There's no other reason for it, right? It means your sugar was more than 150, 180 chronically, okay? Because what does our insulin do? It keeps that sugar under 150, 180. Yes, 200, but it's going to keep that sugar under control. That's the job of insulin. Okay, so if someone comes with an A1C of like 14, for instance, that means their sugar is at 380 all the time, right? You always ask them, hey, what's your sugar usually run at home? About 200, 220, and an A1C is greater than 14, or the A1C is 13. It's like, no, that's impossible, right? Maybe the last few checks, the last couple of weeks, but not over the last 3 months. That's what it was being glycated over the last 3 months. Okay, there are other things you can do, like if someone's not eating, like in the ICU, you can diagnose diabetes. If the sugar is during fasting is greater than 126 twice, you got diabetes. That's one of the older tests that we did, and that tells you have someone that is diabetic. Now we really have to look at to see if they're super sick. You have the SNS firing off, you have glucocorticoids firing off, and that could be the reason why their sugar is elevated too. Okay, so there's such thing as pre-diabetes. I'm not going to get into that. That's more of an outpatient thing where they're at risk for developing diabetes. All right, so the A1C is about 5.6 to 6.4. You're technically pre-diabetic. There's all kinds of targets with A1Cs. Normal is less than 5.6. We got if you have diabetes, right? Your goal is less than 7%. But I thought greater than 6.5% was diabetes. Like if you make the A1C even lower as a target for these patients, just like you have a target blood pressure for your hypertensive patients. If you say A1C of 6.5% for diabetics, they actually get hypoglycemic, the research shows. So we just say less than 7%. Okay, and so yeah, if you're less than 6, if you have like a super tight control, it's like I want to get them less than 6%, they're definitely having hypoglycemia on the outside. And we mentioned that those that have type 2 diabetes, if they A1C is greater than 9%, we're going to add insulin to their regular oral medication therapies. Okay, so yeah, so there's different tests out there. A1C is the best one. We have the oral glucose tolerance test, which is usually done during pregnancy, which is very sickening, where they give this high glucose solution and they test your body's response to that, right? Usually your body should release insulin and it should lower that sugar. But if your body releases insulin to 75 grams of glucose and it takes a long time to get back on the baseline, you might have some resistance happening. Okay, so that's the idea. So the glucose in the hospital should be less than 180. That's usually our goal, and we can look at the last 3 months to see if they're at risk for complications or explains why they're in the hospital in the first place. Oh, you have DKA or you have this going on. So the treatment. So the treatment for diabetes gets complicated because there's, we only have one mechanism to lower the sugar. So if we're not giving insulin, we have all kinds of other ways to sensitize our tissues to insulin or to make our tissues, lower our sugar as much as possible. Okay, so and of course everybody has diabetes. We said like 1 in 11 people has it, so or 1 in 6, whatever it was. So there's a high amount of people who have diabetes. This is breeding ground for pharmaceutical companies. There's a lot of opportunity here because there are a lot of Americans, a lot of people worldwide have diabetes. So you're going to see a lot of different agents out there. It's like up to 11 different agents are out there. Is your patient going to be on all these? No, but commonly they're going to be on 2 or 3 at least. Everybody's on metformin. So everybody and their mom's on metformin. That's why you have to know about metformin, right? You have to know that it's avoided in CKD and contrast procedures and such. So, metformin is usually everybody gets that. So going back to type 1 diabetics. So type 1 diabetics have a deficiency or resistance to insulin. They don't have insulin, so they need insulin. But end of story. They need to have insulin, and we're going to give it in a normal physiologic pattern where they get basal insulin plus preprandial insulin, which is before meal insulin, right? And these guys might get oral hypoglycemic, so their sugar's not under control. How do you know their sugar's not under control? Their A1C is greater than 7, right? Because if they actually have diabetes, you want the A1C less than 7%. Greater than 6.5% means you have diabetes. That's usually for, we're looking at type 2 diabetics. All right, so then that's type 1s. That's easy, right? Add insulin, end of story. And then if the sugar is still high, we're going to add oral hypoglycemic agents, any one of these categories down here. And we'll talk about those. And usually metformin is number 1. That's usually our go-to agent for type 1 and type 2 diabetics. And then we have type 2 diabetics. These guys have a resistance to insulin, right? So we can make the tissues more susceptible to insulin. We can make the insulin that they do secrete stay around for longer, right? So we have non-pharmacological things we can do for these patients because they didn't, type 1 diabetics, it wasn't because they weren't dieting or exercising, right? It wasn't their fault. They had an autoimmune reaction. They had a genetic situation, okay? So diet and exercise is a key piece for type 2 diabetics when they're at risk, when they're pre-diabetic and such. But once the A1C rises above 6.5%, then it's time for pharmacological medications. If we're more than 9%, automatically insulin gets started for these type 2 diabetics. Otherwise, we're going to start some oral agents. These oral anti-diabetics or oral hypoglycemic agents, and they can be up to like 3 to 4 different medications. Just like your really hypertensive patient can be on 3 to 4 antihypertensives, the same thing for diabetes to get the blood sugar under control. So you can separate them into non-secretagogues and secretagogues. Sounds like something you do on a Friday evening after sunset, right? But it is a non-secretagogue means it's not going to make your pancreas secrete more insulin. It just makes your tissues more receptive to it, right? Versus it's making it more receptive to it, or you're getting rid of sugar somehow, right? You're getting rid of excess sugar, or you're not absorbing sugar. That would be a non-secretagogue. Whereas a secretagogue is something that is making our insulin work better. It's making our insulin be secreted more, right? So that's the idea behind a secretagogue. It's secreting a insulin more quickly, right? So for like sulfonylureas and meglitinides, these guys right here, those guys depolarize the membrane of the beta cell, making the beta cell squirt out insulin at the slightest stimulus, right? So you get more insulin around. And if you get more insulin around, you're at risk for more hypoglycemia for sure, right? So we'll talk about those in more detail. So that's the idea. That's how you kind of categorize them. So this table here will summarize the next 3 slides. So you can refer back to this. They all usually have a glucose or G in the name somewhere, right? If there is a glucose lowering medication, but they have a different, luckily the classes make sense. There are glutides, there's there's G-rides, there's G-lides, there's glitazones, there's agliflozins. They all have G in the name somewhere, Okay, so we'll talk about those in more detail. But with a type 2 diabetic, do you want them to gain weight? No, that's going to make their type 2 diabetes worse. So that's why it's not great to start insulin therapy. It's like, oh, so what? The A1C is 9.5, greater than 9%. Let's go ahead and start insulin. You got to be on this. It's really going to set them back. It's like giving a hypertensive patient some medication that's going to also raise their blood pressure, like a high salt diet. It's like, what are you doing? That's going to make the blood pressure worse. But in diabetes, that's what we have to deal with, right? Because insulin is going to store away fats for a later day, right? A rainy day. So whenever someone's on insulin therapy, it's going to increase their weight gain. So it's like an accepted, situation that we have to think about when someone is A1C is really high and they're type 2 diabetic. They have to get the diet and exercise motors turning or wheels turning so they can get off insulin therapy, hopefully. Okay, and they might still have to be on oral diabetics, and with diet and exercise they can get down to the point where they don't need the medications as long as they've not exhausted their beta cells, right? We catch it early enough. So what else makes you gain weight is when you have a gastric motility that is decreased. So that should say decreased gastric motility, right? Or actually, sorry, I back it up. So that is correct. So you have increased gastric motility. That means you're emptying your stomach more frequently. And that means you're going to eat more frequently, right? Because your stomach's empty. So like one of our agents that's really hot right now, our semaglutide, right? Our Ozempic, right? What it does is it backs up our stomach. It decreases gastric motility. It makes it so that our stomach does not empty as frequently. Therefore, we eat less. So it's going to make you lose weight because you're going to be eating less calories. So if something's going to increase gastric motility, that's going to make you gain weight more. So ideally, what we want for our medications here, what's going to be the perfect combination, is something that causes weight loss and something that's going to cause a decreased gastric motility and something that's going to have side effects that are not bad, right? Because some of the side effects can be like hypoglycemia, right? Some of the side effects can be a major adverse cardiac event, or MACE, right? MACE is here, MACE is down here as well. For our thiazolidinediones, they should have MACE on there too, right? So these guys have a major adverse cardiac event where they have like runs of VTAC and VFib spontaneously, or they have really bad cardiac consequences when we give these medications. The other option besides medications is surgery, and surgery does work. It is 83% of type 2 diabetics will get reversal of type 2 diabetes, right, or get better control of the type 2 diabetes at least. Okay, so you can see weight loss is really what we want. We want our GLP-1s, right? Those are our Ozempic and such. Those are going to be great at fixing someone's diabetes. So biguanides, there's only one biguanide, so it should be called biguanide. All right, that's metformin. Everybody's on metformin. It was invented in the early 50s, and there used to be another one out there, but that one's no longer on the market, so we just have one, and that's metformin. And what metformin does is it prevents the breakdown of lactate, right? Lactate was our like debit card, right? So it was our debit card for when we didn't have oxygen, we could convert lactate into glucose immediately. Right? So if we stop that conversion into glucose, well, then you're going to lower your glucose levels, right? Which is what metformin does. Does it cause hypoglycemia? It does not cause hypoglycemia. You still have ability to break down other things if you need to. Right? It just stops the breakdown of lactate specifically. And then what else does it do? It also stops the absorption of glucose in the gut. So in our gut right here, so we have our gut, a little villi in our gut there. It inhibits the absorption of glucose in the GI tract itself, right? And if you inhibit the glucose in the GI tract, that's more energy or more substrate or more food for our bacteria. And our bacteria love glucose. What do they convert glucose into? Farts, right? So that's going to make you have a little GI upset, abdominal bloating and such, and also it's going to pull a lot of water because glucose is a osmotically active substance, so they can have diarrhea and such, right? So it inhibits gluconeogenesis, it decreases GI glucose absorption, and therefore we get the GI upset situation. But the other piece that it does, it also primes our other cells to respond to glucose better, right? Makes our glucose receptors more primed. It makes the glucose transporters make their way to that cell surface so the glucose can get absorbed into the cells, right? So it increases peripheral insulin sensitivity, increases that glucose transporter action. All right, so we get lactic acidosis, which is rare, which is kind of why we avoid it in CKD, or because of that buildup of lactic acid that might occur. So renal failure patients are not on the list, and then they get dye or contrast. They then avoid metformin for at least 48 hours afterwards, right? And of course, we want to avoid nephrotoxic medications. That makes sense, right? To make sure we're not going to develop renal failure as well. And then sulfonylureas, they are bracketed by 2 lethal rhythms, right? So that could tell you that they have what? They have major adverse cardiac events. They can develop MIs, CVAs, and death while on these medications. Now, why would you prescribe any medications like this? Because it's cheap. That's the only answer, right? It's super, super cheap. It's much cheaper than Ozempic, right? Ozempic's about $200 a month, and this is, that's like could be a car payment for some people in the 90s at least, right? So the car payment is going to be, that's something that we got to deal with. Are we going to do that or food, right? So sulfonylurea is like pennies. So what does sulfonylurea do? It primes our beta cells. Our beta cells get depolarized. It blocks little K channels, which are your cold water for your cells. So it stops that potassium from exiting. Therefore, it makes you more depolarized, more at risk for secreting insulin with any kind of stimulus. So that's what our sulfonylureas are going to do. They're going to make our beta cells super edgy and they're going to squirt insulin at any kind of stimulus, right? So that puts you at risk for hypoglycemia. And of course, weight gain, which is also not great, right? So you got hypoglycemia and weight gain are severe side effects of sulfonylureas if it wasn't the major adverse cardiac events as well. Okay, so we have sulfonylureas, which have sulfa in it. So if they're sulfa allergic, we got an option for you. We have meglitinides, right? Meglitinides are just the option if someone is allergic to sulfas. And they're cheap also. They're a little more expensive, maybe $5 instead of $1.50. But they both have the same side effects. They do the exact same action. It's just they're made differently. Okay, so you got 2 for 1 for this guy, and we got metformin. That's 3 of our 11 medications for diabetes. And also when you have sulfa allergies, you have the risk of Stevens-Johnson. So Stevens-Johnson is a body-wide burn where your skin just sloughs off, right? If you have a rash, that's okay, but that's something, maybe it's a cross-sensitivity reaction, but when you have his skin starts sloughing off, that is usually Stevens-Johnson syndrome if it's related to a medication intake. It's quite rare, but it happens commonly with sulfa allergies. And then secretagogues, right? So secretagogues are ones that are going to promote promote insulin activity, right? They're going to make more insulin stay around for longer. Are they going to make you secrete insulin? Yeah, that's what sulfonylureas did, right? But these secretagogues are the good ones, right? You got GLP-1 and DPP-4s, and it's a little complicated, but GLP-1 receptor agonists. So if you break it down, what insulin actually does, all right, insulin gets released, but you also have a precursor to insulin called incretins, and they're called GLP-1s, right? And these GLP-1s are going to stimulate insulin activity, and these GLP-1s bind to a GLP-1 receptor. So if you have a receptor agonist, it's going to bind to it and make insulin get released, right? So we have increased insulin release, right, which is going to decrease glucagon, and when insulin gets released, it makes you yes, it makes your stomach empty more, but this actually works directly on the brain, and it's going to cause a decrease in GM motility, and that's going to then that's going to make you not eat as much, right? So it's going to be almost like an appetite suppressant in of itself, right? So you don't gain the weight because with sulfonylureas you made more insulin get released, but you got the weight gain from it. But here you have the decreased GM motility, which is really going to kind of break the bank, or what's a break parity on the side effects of increased insulin activity. Okay, and these guys are broken down by DPP-4. DPP-4 is a huge name, right? Dipeptidyl peptidase 4. Right? So it's an enzyme that breaks down incretins. Well, what if I stop that enzyme? That would make more incretins around, wouldn't it? And that's exactly what we did here. We inhibited DPP-4. So if we inhibit DPP-4, right, we're going to stop the breakdown of incretins. Therefore, more incretins means more attached to GLP-1 receptor sites, and therefore more insulin activity. So that's how we get more insulin activity out of these guys, right? You may have heard of some of these guys as well. They're sitagliptin, saxagliptin, linagliptin. These are usually PO agents, and they can be given to lower someone's weight and also to improve diabetics, right? are usually our GLP-1 or RAs. These guys are given sub-Q, so they have to get the shot weekly or daily, right? So that's going to, they're not PO just yet. I heard recently that they were trying to get it PO. It's gonna be a big breakthrough, so you get that more on the market. And then in 10 years, hopefully we can get it off the patent list, and then it can be more common. So sulfonylureas and glutamides don't get prescribed anymore. Okay, so that's the idea behind GLP-1, right? GLP-1 tells the brain to decrease appetite. It also going to decrease gastric emptying. So GLP-1 not only makes insulin get released, it also inhibits the brain, inhibits the stomach. Therefore, you eat less because of the brain. You also eat less because your stomach is full. And that's how you get Ozempic, right? You get Ozempic face. So then SGLT inhibitors. So these guys are not secretagogues. These are technically non-secretagogues. These don't make more insulin get released or more insulin sensitivity. All they're doing is they are blocking glucose absorption somewhere. So it makes sense if you block it in the GI tract, the glucose is not getting in the bloodstream, therefore your glucose will be controlled, right? So that's exactly what they're doing, right? You got these carbs that get broken down to glucose with the presence of amylase, and you get a little glucose in there, and that glucose then gets absorbed into the bloodstream. So if you give a alpha glucosidase inhibitor, which is going to stop the receptors, these little sodium glucose transporters, SGLTs, right? These guys, little transporters that are in there in that GI tract, that's going to stop that absorption of glucose. Therefore, the glucose is going to stay behind and your sugar goes down as a result. But it's also great stuff for the bacteria. Like, yes, sucrose, fructose, right? I got all these simple carbs now, simple sugars. The bacteria are super, super happy now. And what are they going to do? You're going to make CO2 gas, and you're going to have a lot of distension, a lot of farting. You're going to also have a lot of glucose absorbs water. You get a lot of diarrhea and farting. And these guys are not the greatest at parties, but at least, and it's really hard to sell this to a patient because that doesn't go away. Like our metformin kind of went away, but for these ones, you're blocking the receptors like permanently, or while you're on the medication at least. So these guys get a lot of a GI upset, and it's kind of hard to sell it to them. So it's not a very comfortable medication to be on. But then we came out this guy right here, and this is like a gold mine that we found in the last 7 or 8 years. And these guys are called SGLT2 inhibitors, because there's SGLT, I think it's 1 for these guys that are in the GI tract, but the 2s are over here in the kidneys. So we have glucose transporters in the gut, and we have glucose transporters in the kidneys, as we mentioned, right? Those guys are the ones that are absorbing glucose, right? They're absorbing glucose as it goes by. And if it gets more than 180, it's just going to spill into the urine. But what if we want to control the sugar and get the sugar down in a reasonable level? Well, why not just inhibit those transporters altogether, right? And that's what these flozins do, right? So they all have flozin in the name, all right? And pagliflozin is the more common one, right? So the pagliflozin, canagliflozin, these guys are all about the flow of urine. They are going to inhibit the absorption of glucose, right, in the kidneys. So glucose gets filtered, and then we absorb 100% of it up to like 180. But what if we absorbed 75% of it? That means our sugars come down by that amount, right? So that's what we're doing. We're stopping all the glucose, and then all the glucose is going to go, we're going to slide all the way down into the toilet, right? So we get a lot of glucose lost in that with this medication, which is great, right? Because where glucose goes, water goes, and that means my blood pressure is under control because I'm losing preload. The other benefit that they found haphazardly is that it also gets rid of lipids as well. So we're losing glucose and we're losing lipids. And since we're losing lipids, we are cardioprotective. We are going to reduce ASCVD. We're going to reduce lipids and the development of hypertension, reducing glucose and diabetes and hypertension too. But that's going to be great by releasing fluids and also being cardioprotective because we're avoiding the consequences that happen from ASCVD and such, right? So CHF patients, it's actually made its way all the way from like number 5, number 6, all the way to number 1. It's actually the first medication should be given for people with CHF because it's going to get rid of fluid, which is like a diuretic, right? And it's going to get rid of lipids, which is kind of what got them there in the first place, and it's going to cure the diabetes, which is just going to make CHF worse. So it's all the way at the top, right? Does it work on ventricular remodeling? No, but it will help out in the end. So that's why like second place, third place is still your metoprolol and ACE inhibitors and such, right? But it's all the way up there at the top now. SGLT2 inhibitors are kind of a first line agent. So you're going to start seeing this a lot more, and then you're going to say, hey, this is for your diabetes, and they're like, I don't have diabetes. It's like because you have CHF, right? Can a diabetic also have CHF? Yes. Does CHF always have diabetes? No. So that's why you'll see this medication also given for CHF patients. Okay, and it causes weight loss because you're losing lipids, right? You're losing water weight too, but you're losing lipids. You can see these SGLT2 inhibitors lose about 2 to 3 kilograms on average, right? And who else was losing a lot of weight? Those are our guys on Ozempic over here, right? Lose about 1 to 3 kilograms. So yeah, it's just almost as good as Ozempic. So if I were you, I just get this guy. The side effects, though, we're going to have losing glucose in the urine. And what do bacteria love? They love glucose. So the bacteria that are in the urine, and there's no farts in the kidneys, by the way, so you're not going to get farts, but you will get glucose being a prime substrate, a prime food for our bacteria. And we can get vaginitis, we get yeast infections, you can get UTIs frequently. So that's they have to have impeccable peritoneal care with someone's on empagliflozin. So usually the obese patients, some doctors or some providers will kind of hold back until they do lose more weight, but then, or they have to tell them, you really have to have great care, otherwise you can develop, a UTI, vaginitis, etc. Okay. Another unique thing with these guys to be aware of, since more and more people are going to be on it, is that it's going to cause a euglycemic decay. So they have all the symptoms of decay, all the labs of decay, except the sugar is 140. Well, why is the sugar 140? Because all the sugar was peed out, right? So usually your DKA sugars are more than 250, more than 300. So these guys are going to have all the DKA labs except the sugar is 150. Right? So they have euglycemic, meaning normal sugar, diabetic ketoacidosis. All right, other ones, we're not going to spend too much time on these because these are not prescribed that often. All right, bromocriptine is going to stop the SNS, and we know SNS raises the sugar. That works. Colesevelam was used with gallbladder, or the hyperlipidemia, I should say, and it does work with like chole stuff. It's going to decrease and bind to cholesterol, and that will help ultimately someone's hypertension and such. We got this amylin analog that got a lot of traction back in the early 2000s, but come to find out it's not as great as our GLP-1s and our DPP-4s and such. Amylin is going to work on the brain and stop the brain from eating, and it's going to also decrease GI motility and help out with weight loss, but it's not as great as those other guys. Those other guys kind of won the race. Okay, and these guys used to be, it sounds like a Jurassic Park. You go past the T-Rex paddock, go past the Velociraptor paddock, and then on your right, you're going to see the thiazolidinediones, right? So the thiazolidinediones, or TZDs, they aren't prescribed as much anymore. One, because they're expensive, but also they cause increased MACE, or increased major adverse cardiac events. So you can see this is also bound by a lethal rhythm, right? Because they are going to put you at high risk for a lethal arrhythmia, or high risk for CHF, which is contraindicated for CHF actually, and it's high risk for cardiovascular disease, right? It actually makes all your cells very, very receptive to insulin, which is cool idea, but it's not as great as our other medications. Okay, so pramlintide, this guy's going to work in the slowing down the gut, works on the brain to decrease appetite, right? It's kind of similar to our incretins, but by increasing insulin activity, but it's not as great as our other two agents, which kind of do a lot of the same things, but better, right? And our colesevelam works in the gut. It's preventing the absorption of cholesterol.